Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today we're talking to Dr. Doug Jacobs from Maryland Healthcare Commission about growth, equity, and alignment in primary care systems. Let's get started. Hello, Dr. Dan. How are you doing?
I'm doing well, Faisel. How are you today?
I'm doing great. It's always great to see you. And Dr. Jacobs, welcome. My goodness, what an honor. So great to have you on.
Thank you. It's a pleasure to be here.
You've had such an incredible vantage point, at the clinical level, state level, at the federal level. Most of our audience are residents and just young, people who are geeky about primary care. And, how does a primary care doctor end up shaping national health policy? My goodness.
Yeah, well, I was always really interested in policy. And as I was going along and learning about the practice of medicine and studying for all my STEP exams, I always had in the back of my head that while I loved seeing patients and treating folks one-on-one, that policy was a way that we could really affect change to the entire system. And a lot of the gripes that occurred on a daily basis about the system and how it should be better, that maybe I could actually have an impact in addressing that. And so it led me first to a state level in Pennsylvania as the chief medical officer, and then to the Center for Medicare and Medicaid Services, CMS, where I was the chief transformation officer of Medicare. So that was the path. And now I'm actually back at a state level in Maryland. I'm the executive director of the Maryland Healthcare Commission. So anyways, it's really a pleasure to be here. And I think that affecting policy change and practicing medicine is a good combo.
Yeah, like when we're seeing today, I was seeing a patient earlier, and when I recalled that we're going to be having this conversation, it's like CMS strategy feels like so far away from regular exam visits, So one of the things we had another call earlier, and I was like, I wanted to help connect some of the dots with these younger residents, especially all of this, like everything that they're experiencing right now can help influence their life trajectory, their career trajectory, and so yeah. So let's get started. I remember Dr. Dan telling me about the goal of getting to the 100% accountable care by 2030, moving everyone into accountable care, into these value-based relationships. I mean, that was a pretty big target.
Yeah, it was. Yeah, in the previous administration in particular, it set out that goal. And I think there's still an interest with the current administration about moving towards accountable care, because it can both save money for Medicare and taxpayers, but it can also just deliver better care when clinicians are working together and sharing information and trying to figure out how to best deliver the care and coordinate care for individual patients.
I heard a quote earlier in the week from James Clear, who wrote Atomic Habits, and he said that you don't rise to the level of your goals, you fall to the level of your systems. And I know right now, we're pretty much still working in a fee-for-service system, and I know you're working on making changes to that, or a lot of your career has been working on making changes to that to move more towards a value-based care system. But how do we create the system that raises the level of care we're able to provide? I think we have laudable goals, but how do we bring up the system that we're working in to give better outcomes to everybody?
Yeah, it's a great question. So I think when we see patients on an individual basis, a lot of clinicians don't think, what is this patient's payer, and how am I going to treat them differently because they have X, Y, and Z payer as opposed to A, B, and C payer. So I think that when we think about these value-based care systems, it's important to take an all-payer approach. How do we shift the way that we are paying, not only for one payer, but also work together across all these different payers in our fairly fractionated healthcare system to really change the incentives. And so accountable care, we were just mentioning, it looks at the overall expected cost of the patients that you're seeing over a year. And if at the end of the year, you're actually doing a better job at reducing inpatient admissions and reducing ED visits, giving them the primary care and preventative care that they need, and measuring quality, then, hey, you actually stand to benefit by getting some of those dollars. And so shifting away from fee-for-service and moving towards value-based accountable care, that alignment can really be critical across payers. And that's when I was at CMS, that was part of my role. It was to work not just within Medicare, but to work with my friends at Medicaid and to work with my friends who were working on the marketplace. And that collaboration can be really important as well.
You know, we see patients who are very complex with, right now I'm with City Block Health. And so we'll see someone who's a dual eligible grandmother. She's got congestive heart failure. She's got issues with transportation. There's issues with just the nutrition that she has. And so, you know, with the ACO PC Flex, the idea was, I guess, to boost primary care funding. But besides the financial, like, how do you see that improving the lives of like patients like this who, you know, the elderly grandmother got congestive heart failure and these social issues?
Yeah, well, I think that primary care, when it's done well, is increasingly being delivered in these advanced primary care teams. And so you have a person who can check up on those high-risk patients with heart failure who might otherwise be not necessarily following their diet. Their weight might be going up because they're starting to retain fluids. And lo and behold, if you don't check up with them regularly, they might end up in the emergency department and admitted. But hey, if you're actually paying more for this advanced type of primary care and you have an interprofessional, interdisciplinary team of care managers and folks that can reach out, maybe it could be a community health worker, it could be a peer support worker for someone with substance use disorder, it could be a pharmacist. There's a lot of people that have a lot to lend to the primary care team. And I think making sure that those enhanced payment rates, that they can actually, when there is those enhanced payments, it can do things like change the practice for the better, such that you can give those patients the time and attention that they need. And you're not just focused on getting patients in and out on a 15-minute basis. And hey, if they need to have their results read to them, you have to bring them back into the into the clinic. I mean, that's not what people want. And it's not the care that I think we think that people deserve. And so providing those enhanced payment rates through Primary Care Flex. And then also I can talk about as part of the physician fee schedule, there's new work to really take all those learnings from advanced primary care and create these new codes, advanced primary care management codes, that advanced primary care teams can use, and they can get paid for this kind of work where, you know, previously, we would have these also, the patient portal messages. A lot of primary care docs have these patient portal messages now. And that wasn't necessarily a code that you could bill for that people were doing with any regularity. There actually is a code that you can bill for, but people don't use it because it's more trouble than it's worth. So this was a way to actually bundle together those communication technology-based codes, the care coordination codes, into a single monthly payment to compensate those advanced primary care practices for all that important good work that they're doing.
It's interesting. I think one of the reasons I think primary care may have done less well over time is because we're friends with our patients over time. And so we see them struggling, we see the grandmother struggling to help her family with school books for the kids and that kind of stuff. So we're always reluctant to ask for additional money. And so I was in a recent conversation with some doctors about the advanced primary care codes, and they were saying, well, we don't feel comfortable asking people to pay a copay on that. And I think I don't think it's only one institution that's having those conversations, but I also know that basically, the law says that Medicare covers 80%, and then somebody has to pay the other 20%. Has there been any thought about how to actually provide those wraparound services without asking patients to go into their pocket and pay on a monthly basis for that?
This is a fantastic question. So advanced, it's going to get a little bit wonky, so I'm just forewarning you. So yes, the short answer is yes. So there are 3 levels of advanced primary care management codes, and it has to do with the relative medical and social complexity. There's level 1, which is 0 to 1 chronic conditions, level 2, 2 or more chronic conditions, and level 3, 2 or more chronic conditions and a dually eligible Medicare, Medicaid patient. And so the dually eligible patients, by statute, they can't pay copays, so they are kind of exempt from this. So it's really that level 1 and level 2 of advanced primary care management patient that we're talking about. And in this year, in this physician fee schedule, actually, there was a request for information saying, advanced primary, as you said, Medicare pays 80%, the patient pays 20%. That's actually the case when it's a treatment, when it's a service. When it's prevention is actually covered with no cost sharing. And what's unique about primary care is that it's a blend of chronic disease treatment, prevention. And so if you're paying on a monthly basis to bundle all of these things together, it's this unique situation where it's not just treatment, it's not just prevention, it's kind of both. And so their request for information is, how does CMS deal with this new situation? Should we still have cost sharing for these services? And so that's an opportunity for the primary care community to stand up and say, actually, no, there should not be co-payments for these services. And if you want to make your voices heard through the comment period now, because the comment period's open until mid-September, then that's a good opportunity to do that.
Yeah, I love that shift. I mean, I remember in residency when we were all being trained on how to properly present a patient, properly document the patient visit and all that stuff. And everything started around like the chief complaint. And then we get into value-based care, and you get into the value-based care world, and it's no longer about the patient's chief complaint. There's a blend, like you said, between whatever the patient's chief complaint may be for that moment and whatever the doctor's primary concern may be. And then there's that art of finding that, and especially like in community health. That was the thing that I loved about the whole value-based care movement, because of all the incentives. You had all this rush of people going into underserved neighborhoods. And that was one of the things that you really pushed, with health equity, it being like a core pillar of all this. Is there a moment that you can share from when you were at Pennsylvania Medicaid or at CMS where like you saw like the payment change ended up leading to a better outcome for a person or a group of people who were historically, they were overlooked?
Yeah. So I think the services related to community health workers, I mean, I think a lot of us have had these experiences where, and you're referencing the patient with heart failure earlier, and that it is just so hard to navigate our healthcare system to actually have someone who speaks your same language, who's from the community that you're from, that has had a similar upbringing, to like talk to you as in a way that you understand, is just priceless for a lot of these patients. And so when CMS started paying for some of these care navigation services, there was many, many different stories about patients with heart failure, with COPD, with cancer, that were trying to navigate their cancer treatment. How do I get a biopsy? How do I then get plugged into chemotherapy and radiation? There's so much complexity in our system that if you didn't grow up with it, or there's some kind of barrier, it can be especially hard. And so I think those questions about what we pay for and the focuses that we're bringing that were brought to underserved areas were really important, definitely.
Yeah, you've said that like the accountable care models have been built on fee for service, like on the fee for service chassis, and so most of us we're trained in that the RVU model, and I think about especially this new generation of doctors, even with all the the community based family medicine residency programs and all, one of the things I worry about is the residents and just the doctors shifting the mindset from the code, the gaming and everything with these codes to using these new these codes that you're talking about, the social determinant codes and navigation codes, rather using them as the training wheels rather than all the other things with the code, with the gaming of the codes.
Yeah, it's interesting. It's the physician fee schedule and the creation of these codes, it builds this muscle memory of how do I actually do interprofessional team-based care in a new way. And so even if one starts out in a fee-for-service architecture, if you're actually paying for some of these services and one moves into accountable care system, maybe that's with upside and downside risk, and you're not as overly concerned with the individual RVU generation, but you're kind of thinking about it on a more global level, that muscle memory can still be important. And the other piece is that the Medicare Shared Savings Program, it's the permanent program in Medicare, just for your listeners, if they don't already know, permanent ACO program in Medicare, 11 million persons covered go to a provider, oftentimes primary care provider, as part of these ACOs. And it's, when I say built on a fee-for-service architecture, the practices still get payment for the services that they deliver, but at the end, it's at the end of the year, the payment gets reconciled. So if this is the benchmark, the amount expected, and you come over here, there's like this gap in between. It's the shared savings pool. And so because of cash flow reasons during the year, it can actually be important that even in an ACO architecture, that there's actually a way to get payment for the services rendered rather than waiting until the end of the year. So that's another piece of why it's actually still important to care about fee-for-service, even if you're in these ACO models. So there's a few reasons. And okay, this is getting very wonky, but that overall level, that amount that you expect the patient to cost, it turns out if you do things like pay more for primary care over time, then those patients that are getting more primary care, it raises the benchmark because you're expecting them to get more primary care. And so that can actually be helpful if that type of care helps to increase your benchmark because it's based on historical spend now. So anyways, maybe I got a little bit too in the weeds there, but
no. I mean, this is we're all living it. I mean, and for those of us who've gone into the value-based care space, it's impossible to go back. I couldn't even imagine going back and worrying about any other, going back to the older models, especially. You know what you mentioned about, the doctors know, providers know, teams are knowing about, being responsible for patient outcomes with the value-based care model, but still many patients don't even know that they're in an ACO. Like how do we, it takes a relationship, like we've passively helped patients feel accountable to the relationship. It's both sides. It's not just the one side. Patients also have to feel like they're part of this. So like, how can the patients start to feel that accountability, and then because of that, it leads to better care coordination?
Yeah, it's a great question. I think it's a question that folks have struggled with over time because on the one hand, you want a patient to be able to go to the doctors that they like. And that's great. And so all the ACO work, it just happens on the back end. So what the patient might be seeing is, oh, hey, I don't actually need to come back to have my results read to me anymore. I can do it via the portal. They might see that, oh, actually, someone just called to check up on me because I was in the hospital recently and they wanted to make sure that I understood all my medications. So they might see those elements of being in a value-based accountable care model. There are requirements to tell patients that they are in an ACO, but they get a mailer and oftentimes don't understand what an ACO is. And it's pretty complex when you actually think about it. So how to actually describe this to a way that a patient will understand. So CMS, I think, in the past several years has done some focus groups to try to make sure that the language in the mailer is actually in a way that people can understand it. And that can help somewhat. But I think also figuring out ways to communicate about accountable care in ways that people can understand and that ACOs can start doing some of that too, and doing some of that beneficiary education and giving them more freedom and flexibility to do that could be a direction that folks decide to head in.
I would love to hear some of your experience. You've been in the Medicaid space, and Medicare. I've gone from Medicare Advantage. I'm back in the Medicaid space right now, and I see that there's just all the gaps. There's so many the differences with the complexity, how we calculate complexity, how we document medical complexity. We got all of that, and so you've had a front row experience on the Medicaid side from Pennsylvania. And there's so many lessons from the Medicaid side, like with community health, integrating behavioral health. What are some of the gaps, or some of those concepts that are still undervalued in Medicare policy?
Yeah, there's a lot of differences. I would say one thing that I came to appreciate after working on the Medicare side, after the Medicaid side, was in particular how oftentimes commercial payers base their payment rates on Medicare. And I think as a result, making changes to the way that Medicare values services has this downstream impact, not just in the Medicare fee-for-service side, but across all the commercial payers, employer-sponsored insurance. Oftentimes, and Medicare Advantage plans oftentimes base their rates on, or they can base their rates on traditional Medicare fee-for-service rates. And ACOs use fee-for-service rates to develop benchmarks. So it's like the building blocks for a lot of aspects of our healthcare system. And I should even say state Medicaid programs oftentimes use Medicare rates as a comparison too. And so some of what recently came out in this physician fee schedule. So how has Medicare developed rates historically? Maybe we can start there. They've taken a lot of feedback from what's been called the Relative Value Scale Update, or RUC. And so by statute, Medicare has to look at how long it's taking to do a service, the different building blocks of the equipment costs and the practice expense of doing that service. And they've relied on this recommendations from the Relative Value Scale Update Committee that they send out a survey to different specialists who do that service. And the response rates are oftentimes in the single digits, and they send it back to CMS, and CMS looks at it, and the majority of the time historically has taken those recommendations. And there's been more and more information about how this is, as you might imagine, when a survey is in the low single digit response rates, there's something different than from those responders to the non-responders. And one might begin to think, oh, maybe it actually has something to do with the fact that they know it might impact their payment rates. And I think it's been especially a problem because on the procedure side, there's these new codes come out for a procedure, and the payment rate is set through this process, and then it doesn't really change that much. It takes on average over 17 years for Medicare to change a payment rate after the procedure or diagnostic test has come out. And so the physician fee schedule is a budget neutral system. This means we're overpaying for all of these services and underpaying for other services, mainly like cognitive, primary care, behavioral health type services. And what CMS is doing in this fee schedule is they're saying all of those services that come out and we don't revalue, actually, they're getting more efficient over time. So surgeons are developing better workflows, proceduralists are figuring out faster ways to freeze off warts. We are, like, the workflows are improving, the technology is getting better, and you can do those procedures faster. You can do a cataract surgery faster than you used to, and you can do so many of them in a day. And if CMS isn't taking that efficiency into consideration, then they're continuing to overvalue all these services. So for the first time in this proposed physician fee schedule rule, they're saying we are actually going to have an efficiency adjustment. We're going to reduce the payment for these procedures, diagnostic tests, radiology, and it's going to have a corresponding increase in the payment for some of these cognitive services. And going forward, every 3 years, we propose that we're going to take this efficiency adjustment off every 3 years, and it will have this impact again and again, accounting for these efficiencies that really haven't been able to be accounted for before. And I mean, the corresponding difference on the primary care side is you can't really get more efficient if what you're billing for is time, because time is immutable. And so if you get more efficient, you just bill for less time. So this dichotomy between procedures and tests and primary care, when residents are going through residency and they're looking at the potential different compensation rates, that is part of what has led to it over time. And so this is, I think, is a really important change. And I should also mention that CMS is saying that, they would prefer to actually look at not these surveys that are probably biased, but they prefer to actually see empiric data. So how long from EMR data, operating room logs, is it actually taking to do these different things? And can we use that to better value services, which can have a really important impact too?
Yeah, this is why we've always felt so, underpowered, compared to these big hospital systems, right? I mean, do we need to shift the power back to primary care? I mean, so what did you learn at CMS about how, like, the payment redesign can actually shift the power back to, I mean, there's less than 100,000 still there's less than 100,000 family doctors out of 1 million doctors. Like, how come payment redesign actually shift the power back to us? Yeah,
I mean, I think it's changing some of these distortions that I'm talking about in the fees. And I think that I think it's really evident that primary care, all the research shows that it's the one specialty where the more primary care docs there are, the better the population health. And actually, the more primary care docs there are, the better reduction in disparities in the community as well. And making sure that we have a healthcare workforce that best meets the needs of our country is incredibly important. And so I think making some of these fundamental changes to the building blocks that have been distorted for so long in the fee schedule, and then making sure that payers all around are making changes appropriately, but not only that health systems are taking those increased payment rates for primary care and actually investing in creating more interdisciplinary teams that can serve more people, make it such that you don't have to wait 6 months, a year, more than that to get seen by primary care. All of that is just critical to making sure that we have a primary care workforce that meets our country's needs.
You've had such an amazing life journey. A few weeks ago, we were in Kansas City at the Futures Conference. And, that's such a great meeting. You get to meet so many people, friends and all. And I ran into a former resident from 10 years ago who was actually applying for a job at my community health center. And now he's like a residency program director doing presentations on AI. And it was just it's so fun to see, that, and when you were a resident at that time, could you ever imagine that you would have been sitting in the table that's shaping national quality? What can the residents currently right now do to get in the room where it all happens?
That's a great question. I really tried to reach out, meet people that were doing work that I found exciting and invigorating and inspiring, and learn about their path. I think it's interesting. When I talk to people who are interested in a career path in policy and medicine that's kind of unique, I know, because I've kind of been there, there's a lot of tendency to want to tell people to do exactly what you did. But actually, there's so many different ways to get involved in policy. And you can go into practicing medicine first for a while and then try to make a switch. And you can continue to practice. You can try to be very diligent about trying to get substantive experiences throughout school and residency and afterwards. And there's fellowships that folks can do. And so it really depends on the person, their individual interest in policy. Is there a specific kind of policy? But I've been really blessed to be around, I think, important work that's really been able to move the needle. And I hope continue to move the needle on these issues related to primary care and health equity and some of the ones that we've been talking about. But yeah, I think it can be really powerful using the individual patient experience and the policy and marrying the two.
Dr. Jacobs, thank you so much for joining us today. Gosh, you're just such a hopeful person. It's amazing to hear, the doctor doing this kind of work about paying for prevention, getting credit, not even paying, but getting credit for it. And, it's just wonderful to hear that, the transactional model, there's no relationship there. And then you've helped push so much of restoring. We talk about restoring the doctor-patient relationship, from a clinical, in our day-to-day, but then people like you who actually are doing the hard work to help make that happen again.
Well, thank you. It's been an honor and pleasure being here, and I really appreciate the conversation. And I want to try to leave folks with some hope and reason for wanting to go into primary care as a career path. The nation needs more primary care docs, and I think that there's reason for optimism amidst a really changing healthcare landscape within primary care now.
Gosh, thank you so much.
What are your thoughts on growth, equity, and alignment in primary care systems? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.